a quick review, the pharmacology of the vasodilators and the treatment of angina pectoris. In normal heart, we have a balance between the oxygen supply and the oxygen demand. In angina, we are losing this type of balance. So here we have a decrease in the oxygen supply and an increase in the oxygen demand. The increase in oxygen demand will be depending on different types of factors. For an example, if we have an increase in the heart rate, if we have an increase in the contractility, if we have an increase in the arterial pressure, and also if we have an increase in the ventricular volume. All of these factors, it will be leading to an increase in the oxygen demand. On the other side, the oxygen supply will be depending upon the coronary blood flow. And that's the coronary blood flow will be decreased if we have a change in the aortic diastolic pressure, if we have decrease, for an example, or if we have a decrease the duration of the diastole, because the blood supply, it will be depending on the pressure and the timing for this diastole. Also, the coronary blood flow will decrease if we have an increase in the coronary vascular resistance. And that's it might be happening because we have different types of metabolic products, or we have an activity of the autonomic nervous system, or if we have a damage to the endothelial tissue. In this slide, I'm going to describe the different types of angina. So here we have a cross section for the normal coronary artery. Here I am drawing a coronary artery that we have a build of the fat deposit in the wall of this artery. That's the one we call it the black. And that will be compromising now the blood supply. So we have a specific narrowing. This narrowing, usually it is a fixed. So we call this type of angina that we call it stable, or the effort induced, or classic, or typical, which means that we have the lumen of the coronary arteries will be narrowed by the presence of this stable black, and will be leading to a partial stenosis. The other types, we call it the Prinzmetal angina. That will be usually result from a coronary artery spasm, or we call it variant angina. That usually will be happening in the wrist. In the opposite, for the first one that I described, the stable or the typical angina, that usually will be happening with the effort, as I mentioned. So whenever we have an increased demand, the blood supply is unable to meet this type of demand. So we have the typical angina, which will be released and disappear within a few minutes of rest, usually. The coronary artery spasm, or the Prinzmetal or the rest angina, as I mentioned, will be happening during the rest, and usually will be happening probably in the early morning or during the sleep. Here I am drawing a coronary artery, and here you can see that we have the black, that it been ruptured and starting now to have a platelet aggregation. Now, this condition will be leading to what we call it the unstable angina. And here we have two possibilities. The first one, that's we have the aggregation of the platelet and the formation of the clot, but still we have the possibility for the blood to get through. So here we have a partial obstruction, and that will be leading to an ischemia in the subendocardial tissue. So just part of the wall of the ventricles will be now damaged. And that's condition here. We have two possibilities whenever we do an ECG. So either we have a non-ST elevation MI, or we have an unstable angina. To differentiate between the two cases, we measure the troponin. If the troponin is not elevated, then we still in the unstable angina. The other condition, that whenever we have the blood clot that it's been so big and totally now make an obstruction. So we have a total obstruction, and that will be leading now to an ischemia and necrosis through all the wall of the ventricles. And in this condition, we have the case, what we call it, if we make an ECG, we'll obtain what we call it the ST elevation MI. And now that's totally different story. We need to treat the patient as a myocardial infarction, giving a strong analgesic and so on. And we'll mention it in another lecture. So here now I already described now a third type of angina, the one we call it unstable angina, that will not be released by rest and will be the pain starting to be increasing gradually until, as I said, it may be reached to the myocardial infarction. So we have seen that the imbalance in the oxygen supply and the oxygen demand is responsible about the symptoms and signs of angina. So let's now take the coronary arteries. I am trying to simplify what is happening in these coronary arteries and what is leading to a decreasing in the diameter. So we'll be producing a contraction, and that will be leading to a decrease the blood supply, and how also we are able to increase the blood supply by producing a relaxation. So here we have the lumen, and here I'm drawing the endothelial cells. One of them I just enlarge it a little bit to be able to show you what it's might happening inside it. And here we have the smooth muscle cell. So in the cell membrane of these smooth muscle cells, we have a calcium channels. So the calcium will be coming through from the blood, will be entering through these channels inside the smooth muscle cells now. And it will be interacting with a calmodulin. I'm going to describe it in a little bit more details in the second slide. And that will be forming a complex. Now, that complex will be activating the myosin light chain kinase, a specific enzyme, so we'll make it an active. Now, the activity of this enzyme now will be converting the myosin light chains to an active form, which means that it will be phosphorylated. And whenever it is phosphorylated now, will be increasing its interaction with actin, and that will be leading to a contraction. Also, on the other hand, we have in the endothelial cells, we have the amino acid L-arginine in the presence of specific enzyme, nitric oxide synthase, that is going now to, in the presence of molecular oxygen and NADPH, it will be producing releasing nitric oxide. Nitric oxide will be diffused through the cell membrane. Now, whenever it is inside the smooth muscle cells, is going now to activate a specific enzyme, cytoplasmic guanylyl cyclase. So this soluble enzyme now, it will be activated and it will be converting the guanine triphosphate to a cyclic GMP, cyclic guanine monophosphate. The cyclic guanine monophosphate is going to activate a specific enzyme, phosphatase, I'm going to mention it, and that is going now to take the phosphor from the myosin light chains. So it will be, now it will not be able to interact with actin, so that will be leading to a relaxation. Also, we have the rheokinase, a specific small G protein enzyme, that it will be inhibiting the conversion of the phosphorylated myosin light chains to a non-phosphorylated one. In another explanation or another mechanism, we have here I'm just drawing the potassium channels to know it in the cell membrane. So we have a beta-2 receptors in the cell membrane. So by stimulating the beta-2 receptors with a specific agonist, that is going to activate the adenylate cyclase, which will be converting now the adenosine triphosphate to a cyclic AMP, cyclic adenosine monophosphate. And again, cyclic adenosine monophosphate now is going to work through the myosin light chains kinase to convert it mainly to a myosin light chain kinase, the one it's been phosphorylated, which it will be inactive here in this case, because we are now taking it away from the calmodulin. So that's finally then will be leading to a relaxation. Now let me explain the previous slide in a little bit more detail. So here we have the structure for calmodulin, which it is a 148 amino acid. As you can see it here, it will be binding for calcium. So that will produce calcium calmodulin complex. Now this complex is going to activate the myosin light chain kinase. And the myosin light chain kinase, I'm going to describe it in a little bit of details, what it will be happening. So here we have the head of the myosin and the rod or the tail of it. And we have also a two-part, which we call it the light chain. So we have the essential part of the light chains, and we have also the regulatory part. Here we have the phosphorylation. So whenever we are activating the myosin light chain kinase, is going to phosphorylate the regulatory part of the light chain and is going now to increase its interaction with actin. So now we have the myosin head will interact with actin, and that will be leading to a contraction in the smooth muscle in the coronary arteries. On the other side, we have seen that nitric oxide is going to stimulate the soluble guanylate cyclase, and the activated guanylate cyclase will be converting guanine triphosphate to a second messenger cyclic guanine monophosphate. The cyclic guanine monophosphate will be activating the protein kinase G, and this activated protein kinase G is going to activate the myosin light chain phosphatase. And this enzyme, the myosin light chain phosphatase, is going now to dephosphorylate the regulatory subunit from the light chain. And by dephosphorylation of that regulatory light chain, that is going now to reducing the interaction between myosin and actin and to produce a relaxation in the smooth muscle. In the heart and in the kidney, we have the beta-1 receptors. The stimulation of the beta-1 receptors in the kidney will be releasing the renin. Renin is going to activate the system renin-angiotensin-aldosterone, and also will be releasing the antidiuretic hormone. The release of antidiuretic hormone and the activation of the renin-angiotensin-aldosterone system will be leading to an increase in peripheral vascular resistance. Also will be leading to an increase in the stroke volume and contractility, beside an increase in the heart rate. The stimulation of the beta-1 receptors also will be leading to an increase in the stroke volume and increase in the heart rate. So all of that, the increase in the stroke volume, increase in heart rate, will be leading to an increase in cardiac output. So beside an increase in peripheral vascular resistance, that will be leading to an increase in the arterial blood pressure or the afterload. So now using a medication to block the beta-1 receptor selectively, by blocking the beta-1 receptor in the kidney, we are preventing the release of renin and preventing the activation of the renin-angiotensin-aldosterone system, beside blocking the release of antidiuretic hormone. And by blocking also the beta-1 receptors in the heart, we are going to decrease now the stroke volume and the heart rate. So all of that will be leading to a decrease in the peripheral vascular resistance and decrease in cardiac output, and finally a decrease in arterial blood pressure or the afterload. We already noticed in angina that we have imbalance between the oxygen demand and the oxygen supply. So by this medication, by blocking the beta-1 receptors, mainly here in the heart, we are going to decrease the contractility, decrease the heart rate, decreasing the cardiac output, and decreasing the blood pressure. So which means that we are going to decrease the myocardial oxygen requirements. And also we are going to increase the diastolic perfusion time, so which means that we are going to increase the coronary perfusion, so which is going to increase the oxygen supply and decrease the oxygen demand. So by this way, we have an improve in the oxygen supply demand balance in the heart. The major beta blocker being used in this condition here: atenolol, metoprolol, labetalol, and carvedilol. And all of those, they are supposed to be a beta-1 selective blocker. Unless we are increasing the dose so much, then they will be losing their selectivity and they are going to block the beta-2 receptor and will be responsible then about the side effects that will be produced by this medication. Now, some of the side effects that will be produced by the beta blockers, it will be very easy to be explained. So we know that they are going to produce bradycardia. That's because, again, they are now blocking the beta-1 receptors in the heart. The same, because they are blocking the beta-1 receptor in the heart, they are going to depress the myocardial contractility. And also they are going to depress the excitability of the heart, because some of these beta blockers, they have also a local anesthetic action. So that they produce what they call it membrane stabilization. So that will be decreasing the excitability of the cells. Also, they are going to produce some kind of fatigue, mild sedation, vivid dreams, and sometimes they might be leading to depression. That's because some of them will be crossing the blood-brain barrier and will be affecting now the production and release of the norepinephrine and some other neurotransmitter in the brain. Also, they are producing a cold hands, and the same, they are going to be worsening the pre-existing asthma. So the cold hands, it's understandable because they are going to block the beta-2 receptors in the blood vessels, which usually the stimulation of the beta-2 receptors in the smooth muscle in the blood vessel will be leading to vasodilatation. So now you are producing vasoconstriction. The same can be explained with the worsening of the pre-existing asthma, because again they are blocking now the B2 receptor in the smooth muscle in the bronchi. And they are masking the hypoglycemic awareness. Those who are receiving some medication to control the blood glucose, like insulin, for an example, the major toxicity or side effects to produce hypoglycemia. So the patient will know that he is hypoglycemic whenever he has a tremor and increase in the heart rate. So the beta blocker will be preventing the tremor and the palpitation, so he will not be able to know that he is suffering from hypoglycemic effect. And at the same time, they are going to prevent the adrenaline from stimulating the liver to make more glucose. The beta blockers are recommended as initial anti-anginal therapy for the different types of angina, except for sure the prinzmetal angina, because that blocking the beta receptor in the smooth muscle in the coronary artery is going to increase the spasm and will be decreasing the blood flow through the coronary arteries. The beta blockers, they have a very good advantage in reducing the mortality for those who are having a myocardial infarction. So they will reduce the mortality after myocardial infarction, because we know that in myocardial infarction, the major reason for death is the arrhythmia, which will be result from the overactivity of the sympathetic nervous system, because just as a compensatory mechanism. And here, by blocking the beta-1 receptors, you are decreasing now the stimulatory effect of the sympathetic nervous system upon the heart. The same if we have heart failure, they are going also to reduce mortality, again because in heart failure we have an overactivity of the sympathetic nervous system, and that is going to stimulate the heart more to produce more contractility and increase the heart rate, which is the heart already now, he is already have a serious problem. So that will be leading to increase the mortality. So if you block now the beta receptors in the heart, you are decreasing now the overstimulation of the heart through the beta-1 receptors. Usually in these two conditions, or even whenever we start to manage the angina, usually we starting with a low dose and we going slow. So usually we try to keep the dose in accordance with the heart rate between 55 and 60 beats per minute. Now, this medication the beta blockers, they should not be stopped suddenly. We need actually to just to go about like 2 to 3 weeks, decreasing the dose gradually to avoid any rebound angina or myocardial infarction or hypertension. Why? That's because whenever we are using any medications that will block the receptors, then the system will receive as if we have a decrease in the number of the receptors. So that will be leading to a supersensitivity or an upregulation of the receptors. So we have an increase the number of the receptors. So if you stop now the medication suddenly, you are exposing now these receptors to an overstimulation with the normal neurotransmitters that present there, and we are getting a very high response because now instead of stimulating, for an example, originally 2 receptors, now we are stimulating 4 receptors. Just I am giving an example.